Hey, folks. I am really pleased to have our guest on today. Peg Sandeen is joining us. And Peg is a social worker with over 25 years of experience in end of life care, has a really amazing personal story as well as to what brought them into this work. And Peg is also the CEO of Death with Dignity. So we're going to be learning a lot about end of life care, what the policies and rules are, especially related to dementia, which some of us are just learning the limitations to death with dignity and end of life care with folks who have a type of dementia. This is just going to be a great conversation, I know. So welcome, Peg. Thank you so much for joining us today.
Oh, hi, Laura, and thank you for having me. I'm so excited to be in conversation about this very important topic with you this morning.
I agree. We were just kind of touching on the fact that, kind of the obvious fact that we're all moving in the direction of death, right? That's the only guarantee to life is death. And so it's always amazing to me how this topic isn't discussed more. It's still taboo. It has been throughout time, and it is continuing to be. So I imagine you meet a lot of people that are maybe, I'm guessing, a little nervous to talk about it, or not sure even what to ask, or how to open this conversation.
I have two different stories that I'm thinking about when you open up with this, and one is a funny story. So I'll go with that first, and then I'll go a different, more serious direction. But, I'm the daughter of a hospice nurse. And so in my life, when I was growing up around the kitchen table, my mom would talk about dying. Dying was very, very normalized in my family. And I say this is somewhat a joke and not a joke, is that when it took me, when I went to college, I sort of figured out that other people didn't talk about dying around the dinner table like I did. Like I was like really different in that one little sense. I was so fun at parties, right? I kind of had to figure out like, this is not the topic of conversation in a college party. But it really, I think that it goes to what you're saying. It's like, we're all going to die. We all have loved ones who are going to die. And it is one of the only enduring things that we will all experience. And yet we have this taboo and we don't talk about it. And I think that is one of the biggest challenges that I face as a social worker in end of life care is people wait until the time when they're dying to actually begin the conversation. And that's a really hard time to have the conversation. It's much easier to have the conversation when someone is alive and well, and there's not so much pressure to make decisions right at that point.
Yeah, I've been seeing too, and I don't know if you have as well, but it seems with the baby boomer population, the big massive change makers that were born on the planet, during this certain time, that they, and I know obviously I'm making a generalization here, but it seems like they're demanding a different way, that they're the ones that are asking these questions. They're the ones that are saying, hey, I don't want to face death in a traditional way that my parents did or my grandparents did. And so I'm seeing these questions being asked more and more, whether it's a spouse, somebody that's caring for a loved one, or whether it's adult children caring for their parents and watching this process and learning from that, and recognizing that they want it to be different for themselves and their loved ones. And so I'm wondering, I would love to share with our listeners just kind of what brought you into this work. It sounds like you have a history with your mom that was unique. It's so interesting what brings us into what we do, but I'd love to hear more specifically what brought you into working with Death with Dignity, and then we can talk a little more about that too.
So I think that many people who I meet who are in the Death with Dignity movement come to this movement because of a personal experience. And I've been in this job for 17 years now. So I've been doing this for a really long time. And I hear so many stories, but my personal story is that when I was very young, I was 25, 26, 27, I was married to someone. His name was John, and he was diagnosed with HIV. And this was in the 90s when HIV was very much a death sentence. But the death sentence came at the end of a pretty ugly period of dying, a period of dying that brought a lot of suffering to the person. And John was the same way. He suffered greatly. And, I think sometimes I think about in my life, it's contextualized because of my age, because I was like 26 and he was 33 when he died. But I do think moving forward, some of the challenges that we face would be the same if we were 50 or 80. So sometimes I talk about age and it matters and it doesn't matter. So I do want to just name that. But he was very, very ill, as you might imagine, someone with HIV in the 90s, including AIDS-related dementia. And, I was forced to work. We were very young. I had a 2-year-old at the time. And so I had to stay employed to keep insurance, to keep his health care. And for those of your listeners who are caregivers, right? And you understand this. I'm not sharing anything, like you understand the bucket I'm looking into when I talk about this. And so I was working, and we had to have hospice involved. I had to have support. And, he died at the end of this very, again, so much suffering. And the challenge is that when he was first diagnosed, like we sort of understood the path that would come before us. And he asked me to end his life. And I couldn't do that. I mean, that's murder. And again, this is something that for the caregivers who are listening, they understand this very, you can get put in positions that you never imagined that you would be in, or that there are no answers to, there are no good answers to.
What was that like for you? Because I talk, with families all the time who maybe a couple is working through a new diagnosis. One of them has a new diagnosis, and that conversation comes up almost 100% of the time, is what is the end going to look like, and what control do I have over that? And that position of being put in as a spouse or a family member. And so I'm curious for you, at 26 years old, hearing your spouse tell you that they just want to die, or they want you to help them die. What was that like?
Oh, it was so incredibly difficult. I mean, I can't even, like, what words like are about difficult, right? Like, it was a morass of ugliness. I don't even know what else to say. But I think that I was in shock, right? Like we had this new diagnosis. It was completely unexpected. It came on Thanksgiving Day. And again, I'm like 26 years old. Like, it came on Thanksgiving Day. And it was immediately like we knew the end. We could see the end already, but he was healthy. So this is the same experience. Like, you have someone who seems well, but they're not, right? They have something going on that is kind of invisible. It's very invasive. It will kill them. And, I think that what happens is you just jump to all the horrible things, and you consider all of them, and like a hastened death, or, like whether or not you're going to end your life, like all of those questions come up. And I think about it, like, I don't even really know how to put this into words, but to say, like, it seems reasonable to me when you have such a horrible, like, you've learned this diagnosis, that you go through all the scenarios. That seems very normal to me. And yet with something like dementia, or diagnosis of dementia, or diagnosis with HIV, the different scenarios can be very horrible. Right. And so that's, you asked me what I felt. I intellectualized my answer, but it was hard. I mean, that's what I could say. And it was just kind of like unimaginable. Like when you think of your life at 25, you don't think about this question. And I think when you're 52 or 80, like this, all of the scenarios that you consider, it's just so incredibly difficult.
Yeah. Yeah. And and when I talk to people too, we talk so much about wanting the suffering to end. There's this, you don't want to lose your loved one, obviously, and yet you want the suffering to end, that piece of, and so how do you get to the place of, how you feel about that? But
Yeah, well,
uh,
I kind of think about, I think about medicine a lot. I'm kind of a health policy nerd. I teach health policy. I'm an academic. And when I think about dying or even, dementia or a terminal illness, I think that in society in the United States, we view it, if you have a dementia, we view it as a medical problem with a social aspect. And I wonder if we view it as a social problem with a medical aspect, we might think about the suffering differently.
oh, to say more about that. Tell
Well,
us
I,
more.
you know, I think when we imagine the healthcare system that we have in the United States, it's so treatment focused,
Yeah.
right? And we don't have healthcare as a human right. We have healthcare as a commodity that is bought and sold, and so that concept's really, we have to dig into that because we have the healthcare system that we have, that it's really about treatment, a treatment focus. When we train doctors in medical school, we train them to treat, right? There are no standards for medical schools for end of life care. A physician can go all the way through medical school and have no training on how to do end of life care.
Incredible.
Completely. It's incredible because we have this treatment focused society. And so what I imagine when I'm working with people, and again, from the social work lens, I do see the importance of medicine with someone who has a terminal illness, but also there's the spiritual aspect, there's the family aspect, there's the caregiving aspect, there's the grieving aspect, there's the community aspect. Like, people who are dying are kind of hidden. We don't really see it as a community issue. And so I, like, in my social work head, I'm like, what if this is a social issue with a medical component rather than a medical issue with a small social component? And I think we would approach people who are dying or approach people with dementias very differently if we had that lens, but we don't. We
I
have this
love,
treatment focused lens.
thank you. Yeah, thank you. That I love the shift of perspective in that way. And it would be so interesting, right, to see how things would look different or could look different, if we shifted it in that way. Wow.
Well, and if you think about people's perceptions, like, people think, who are not in this experience, right? People who are not caregivers, they think like the doctor's there all the time, or the doctor's there when you're dying. And we who are caregivers, who have been caregivers, we know that that's not the case, right? Like, the doctors come in, they prescribe, they adjust medications, but really it's us as caregivers, it's nurses, it's social workers, it's volunteers,
Yeah.
it's nursing home staff, whatever it is. And so we have this like lens, like, oh, this is about medicine. And this is not about medicine. This is about caring.
Mm. It's almost a reclaiming of that,
Yeah.
experience, that space, that,
Yeah.
yeah.
Very much so.
Oh. So let's talk a little bit about, let's jump into the death with dignity piece, just so that folks can have a better understanding about what it is, what's going on, policy wise, in the country, in different states. And then I'd love to get a little bit of education about how that applies to folks with memory impairment or dementia as well.
Yeah. So 10 states in the United States have a piece of legislation, and it's broadly called Death with Dignity, or sometimes the medical procedure is called medical aid in dying. And what Death with Dignity is a piece of legislation that tells a physician and a patient all the steps they have to follow to request a hastened death or to request medication to end their life. And almost all the statutes, the 10 different statutes in the United States are nearly identical. And so I can talk about Oregon, which is the first state that happened in '94, or I could talk about New Mexico, which is the most recent state that is just getting ready to have its first year sort of anniversary of having Death with Dignity available. And the laws are almost interchangeable with a few minor tweaks depending on the jurisdiction. And essentially, at its core, What the Death with Dignity bill allows is a person who is terminally ill to say to a physician, I would like a medication to end my life. And the Death with Dignity law tells that physician how a person would qualify, all of the steps to qualify. And that is, I mean, we think of it as a standard of care. This is what physicians have to do.
The medical model, yes.
It's a medical model. And what because medicine, the AMA is opposed to Death with Dignity, but state medical societies have actually moved to neutral on the issue. A majority of physicians support Death with Dignity. And so typically we would think of the medical model being established in medicine, but because medicine is sort of split on the issue, that's why we have legislation about it. Like legislators say, this is what you're going to do. If medicine's not going to regulate itself, the state will regulate it. So 10 states have regulated this. And essentially you have to qualify. So go into the specifics here. You have to be terminally ill with a prognosis of 6 months or less to live. You have to be mentally competent to make and communicate healthcare decisions. And you have to be an adult. So those are the three basic kind of qualification standards. And 2 physicians have to examine you to determine that you meet all of those things. So again, terminally ill, 6 months or less to live, which is the hospice also prognosis qualification standard. And then the mentally competent to make and communicate healthcare decisions, and an adult.
So that mentally competent piece, is that during the time of the visits with the doctor clearly, but also at the end?
So it is for the visits to the doctor. So again, if you think about how medicine works, when a physician writes a prescription, they don't continue to necessarily follow the patient as the patient takes the prescription. They do, but we have this perception that a physician is always there, and we as caregivers know that that's not what happens.
Yeah.
But most people who ingest Death with Dignity medication to hasten their death do so with the help of a statewide nonprofit or a physician or a healthcare provider there. And so for the most part, that those providers ask the question, like, do you know what will happen if you ingest this medication? And if the answer is no, or someone says, oh, I'll wake up and feel better, then that medication is not given to the patient. But that is not part of the law. That's the practice of how it works, but it's not codified into law.
Okay. Thank you. Yeah. This is such a, I'm curious to hear what some of your stories or experiences might have, that you have heard or witnessed around either the decision-making piece, because I imagine there are people that have gone through meeting with doctors and then decided not to follow through with a decision to end their life, and folks that certainly have. I wonder if there's a story or two that you could kind of share to highlight what that journey might look like for someone.
Can you ask the question again, Laura? I'm sorry.
Yeah.
We've been going so well, but my internet just sort of like cut out. And
No problem. Well,
sorry about that.
No, that's not a problem. We'll have our editor tweak this too.
Yeah.
So I'm curious if you can share any stories about what it is like going from, beginning to end, as far as somebody making a decision to meet with physicians, to follow through with at least having the option. Because I'm guessing that some people may meet with the doctors, get what they need to end their life, and then decide not to as well. And I'm kind of throwing multiple questions in here, so you just share whatever comes up. Okay. But I also thought, can you talk to us also about what does that look like? Is it a pill? Yep. Is it liquid? Is it multiple pills? And are states different and what they choose to use?
Yeah, I can. So in terms of people qualifying, or stories, one of the things that I find so interesting is that because becomes a political debate, right? Like, and becomes part of politics, people think that this is so incredibly controversial and people don't know, and whether or not they use death with dignity. But really, in my experience with patients, folks who get to this point are resolute, right? They tend to be calm. There isn't a question like, oh, should I do this or not? Like, they understand the course of their illness. They understand the course of their treatment. They know that they are dying. Like, this is not a group of people who might recover from pancreatic cancer and be that one person who recovers. That's not these people. 95% of people who ingest death with dignity are enrolled in hospice. Overwhelmingly, they have health insurance, Medicare, Medicaid, private insurance. They're insured, they have good care. And so there's this perception politically that this is controversial, but in my experience, the people who visit a physician to qualify for medical aid in dying really are resolute, and they know that it's time. They know they're not going to survive their diagnosis. And so there's a sense of calm. So that's a thing that happens, is that they very much kind of have their ducks in a row. There's a process you have to follow. It's very much like being a caregiver. Like, you have to get everything right and all the forms right. Like, there's those steps that a patient has to go through. And as you know, that's really hard when you're dying or when you're very ill. But it's only the patient. So it can't be the caregiver. So the patient has to ask the physician, then the patient has to put it in writing, and then there's a waiting period, and then the patient has to ask the physician again. Those are some of the steps
How long is that waiting period? Just out of
it's,
curiosity.
it's different in every state, but it's about 2 weeks. It's about 14 days. Some states have 2 waiting periods where there's a 14 and then a 2-day waiting period for the prescription to be written after a person is qualified. Other states, Vermont just took away that second 48-hour waiting period. Just this week, the governor signed the bill, or last week, I guess. And so that waiting period, but you asked about a patient's story. One of the things that is really fascinating is that if a patient is choosing a hastened death, they're choosing the timing and manner of their death, they very frequently bring their loved ones around, right? And so there's this moment where family gets to come together, and it looks all different ways. Like, if it's a raucous family that throws a big sort of alcohol party, like, there's that. Or if it's a quiet family that's praying, it's that too. But that's a hallmark of death with dignity, is that so many loved ones get to come around together, whether it's the moment that the person is ingesting the medication or the day before. And it's so, again, as a social worker, it is so enriching. The family, I mean, they're sad. They don't want their loved one to die, right? But they do want the suffering to end, and they do want to honor their loved one's wishes, and they want to be there. And again, I'll use the word sort of in celebration, and it's not like we typically think about celebration. It's more like that, the love, the reverence, the being together.
Honoring. Yeah.
And it just
Wow.
looks like, if you think about what it looks like what that family looks like,
Right. It's as
however they celebrate things.
as unique as each individual can
Each
be.
individual. Yeah. And it is such an honor and privilege to be a part of that. I mean, I just have to say, to be invited into that is so, again, it's just an honor, I would say.
Absolutely. So can you tell us a little, tell us about the medication piece. What does that look like?
Yes. And I also want to talk about the people who choose not to ingest the medication. So the medication right now, it has changed over time, and each state that has a death with dignity law publishes annually a report to the people of the state that's available. If you live in a death with dignity state, if you live in Oregon or Washington, Vermont, New Jersey, California, Colorado, if you live in one of these states, you can actually go to your public health website or your state Department of Health website and read the statistics. And they each report on which drugs people use. They report a whole bunch of information, but the medications that are prescribed are available, or people can see what they use. And it tends to be a cocktail that a person drinks, right? And so that's the easiest point. Essentially, it's an overdose, right? I mean, if you think in what is it? Like, like straight up, what is it? It's an overdose. And so you can't take a whole bunch of pills at once. So, it tends to be a liquid. It's a combination of a whole bunch of I think 3 or 4 or 5, depending on the formula that is used, medications. In some places, the pharmacist actually comes to your house. Pharmacists are really important parts of our healthcare system, and there are some pharmacists who take this very seriously. They want the patient and the family to understand how the medication works. And so I have seen that, but it's a liquid medication that a patient drinks. It's very bitter. It tastes very bad. I mean, that in our movement, people talk about that might sort of be strange to your listeners if they haven't had this conversation before. But I do want to talk about the patients who choose not to use to qualify, but actually don't go on to use the medication. So about 1 in 3 people who qualify to either get a prescription or fill that prescription end up dying from their underlying condition. They don't hasten their death. And if you think about, I mean, and again, we as caregivers know this, one of the things that happens when we have a really devastating health diagnosis is that things get taken away from us, right? We can't drive anymore, can't work, we don't leave our house, and then we don't leave the living room, and then we don't leave the bed. And so our choices or our options in life get peeled away. And what Death with Dignity is it's one more choice to actually add, right? Like if you're thinking about what are my end of life choices, Death with Dignity is one. And so for some folks who go through that process and say, oh my gosh, I want this choice, they're able to tolerate their symptoms every day. And so they opt not to
Because they
end
know
their
it's
life.
there. If
They know
they
it's there. It's
know it's an
peace of
option if they
mind.
change their mind. Yeah.
Yeah. And really, it's a large number. I mean, I feel like a third of folks go on to do that. And I feel like that's a big number.
Mhm.
Like a
Yeah.
third don't hasten their death.
Yeah. Thank you for sharing that statistic. That I think that's important. And again, these are folks that have gone through with the appointment, that have gone through with filling, getting the prescription, and then waiting or
Yeah.
deciding.
Well, and they've gone through the waiting periods. They've had 2
Mhm.
physicians evaluate them.
Yeah.
They've done a written request, and they've had witnesses sign it, like all of those things.
Can we talk a little about dementia? Because this is one area out of the 3 criteria. The criteria you need to meet is that you have to be mentally competent in order to access this. And so clearly in all these 10 states, somebody that has, I guess I wouldn't go so far, and you can correct me, is it's not that they have a dementia diagnosis, it's that they're not competent to make decisions, right?
Right. Yeah. So that's always the challenge. And so typically a person with dementia, memory related issues would not qualify for Death with Dignity because they don't hit both of the issues at the same time. They don't have a terminal illness with a prognosis of 6 months, but also are mentally competent to make and communicate healthcare decisions. And so it's not that the law says you can't qualify if you have dementia. It's that the standards or the steps for qualifying, you don't meet those, or you can't become a qualified patient. And that is so incredibly difficult for someone with dementia. I mean, I would say it's the number 1 question I get when I'm speaking.
Yeah, I bet. Oh, I bet, because it's up for so many people are experiencing that. Do you foresee change in the future in that area, in that arena? What is the talk going on in that community about dementia?
I don't see a change in terms of allowing people with dementia to qualify. And one of the reasons is that would move the United States to a place where euthanasia is allowed, because someone else would have to make the decision for you. Okay. And I don't think that is going to happen in the United States. at all. We do see it's legal in Switzerland, in Belgium, in Canada, somewhat. But for the most part, it is not lawful any place in the world except for those kind of 3 jurisdictions. And a couple of other countries have passed recently. And I think that we'll see, or it will play out whether or not the qualification standards are how they are. But right now, there's only 3 places in the world where it's allowed. So I don't think in the United States that it's coming anytime soon.
What were those places?
Switzerland, right? And then Belgium and Canada.
Okay.
So Canada had a Supreme Court decision several years ago where the Canadian Supreme Court said that if you are suffering, right, and if you have a long-term illness or suffering illness or terminal illness, you had a right to access hastened death or death with dignity. And then each of the provinces passed laws to talk about how to put that into place. And so the differentiation here is in the United States, each state has said you have to have a terminal illness. And in Canada, that's not necessarily the case.
They based it, it's more on the level of suffering.
The level of suffering and also
allowing someone else to make the decision for you if you're not able.
Well, you have to have sometimes said, like, this is what I want. Right? This is what I want.
So getting something in writing, like in your advance directive, or I guess I'm not sure what that would look like there.
Yeah, I am no expert on the Canadian law. I'm at all.
Come on, Peg.
I know. I know people, but I'm no expert on the Canadian law. I think, really in the United States, the place that we see more people, and this is not a great number of people, but Amy Bloom just wrote about this in her book, In Love, where going to Switzerland to access their services, where they're the only jurisdiction in the world that allows someone who's not a Swiss citizen to use the law. And so a few folks with dementia have managed to qualify. It's very, very difficult to qualify. It costs a lot of money. It's a tough path if that's a path that someone chooses.
Okay. Thanks. Yeah. Thanks for bringing that up, because I had been hearing a little bit about Switzerland and someone's experience.
Yeah, if anybody is curious, I mean, I would really encourage them to read that book, because I think that she does such a nice job of describing, and she really tries to describe her husband's experience. So what is the patient feeling? What is the person feeling? She does a really nice job of telling his story and tries to get away, out of his way to tell his story, even though she's the author. So I think I really appreciate that book.
Nice. I'll put it in the show notes for sure.
Yeah.
It's by Amy Bloom, In Love.
Yeah.
Title.
Yep. That's what it is.
Fantastic. So knowing here in the US, we do not have access to death with dignity for ourselves or individuals that are not mentally competent to make decisions. What would a dignified death look like for those who have dementia? What can family members be thinking about?
It is so incredibly difficult. I mean, there are not good policy answers. And that's frustrating for me as a social worker when I'm faced with a family or a person with a new diagnosis of dementia. It's scary, it's hard, and there's not good answers. And, I think that I lean back into my social work training to make sure that families and people communicate their end of life care wishes. Write it down formally in an advance directive or a living will or whatever format, or a POLST or a MOLST. Those are when your advance directive or your end of life care wishes become part of your medical record. That's what a POLST is, or sometimes it's called a MOLST. So making sure that your end of life care wishes are known.
Mm-hmm. Mm-hmm.
And then also I think about, like, I have a daughter, I think about, she would probably have to make decisions for me if I ended up with a dementia or an end of life something that I couldn't make my own decisions. So making sure that she knows what I want, right? So she feels empowered. And so I think about things like, what would be good markers for her? And I love my coffee in the morning and to read the paper and to do the crossword puzzle. Now I know that that's not going to be like, like my entire life. The fact that I might be able to do that or might not, it's probably not a reality that, if I live very long, that at the end I'll be able to do that. But enjoying coffee, right? Or enjoying something as much as I enjoy coffee. If that's gone for me, I sort of think like those are markers that she can begin to think about, I don't want further care.
God, yeah. So being clear, I wrote a couple of these down. The importance of having your wishes stated in an advance directive or a POLST or I haven't heard MOLST. What does MOLST stand
Medical
for?
orders.
Medical orders for
I think like
life-sustaining
maybe
treatment.
Maryland and a couple of states use MOLST instead of POLST. It's the same thing, but it just has a different name.
So POLST for our listeners is physician's orders for life-sustaining treatment, and MOLST is medical orders for life-sustaining treatment. And that form is pretty much a checkbox medical form for folks to mark if they want interventions, if they want to be resuscitated or not.
Right. But I also think, so that's the formal form, I think is important. But I also think these informal conversations to get, again, this concept of markers, like if I can't really enjoy my coffee and say I switched to orange juice and I'm loving my orange juice, that's fine. Like I don't, but like that a moment of enjoyment, if I don't have that anymore, and so
how to support your decision makers in following your wishes, because that's an incredibly difficult place for a family member to be in,
right,
or a friend to be in, whoever you have chosen. And the thing that I would say too is that many people don't understand, I'll just point it out, is that POLST form and MOLST form that we're talking about is a form that medical professionals will follow if they're not able to reach your decision maker. So that decision maker, whoever you choose, can choose to change that, to change the POLST form, or so choosing that person wisely, I think, is also very important. The person that's going to speak on your behalf or make those final decisions for you.
Yeah, we call that person an agent, and choosing the right healthcare. I think that we think like, oh, our kids are like, I gave the example of my daughter, but for some people, that's not the right decision maker for them. And it's okay. Like you have to be okay with that because it's your life and you get to decide who is your decision maker for you. And it might be more of a neutral friend. Right. Like that might be a better decision maker. And that would be fine. You get to make that decision. Another thing that I think is really helpful is if you record a video or if you put it in writing, because, it's like my daughter and I'm 55 now, my daughter is 30, we have conversations now, say I'm 70, she might not remember. If I record a video, she has something. And then I think that those pieces kind of form a body. So it's the POLST, the MOLST, right, which is the formal piece. And then also if there's this informal conversations about markers or things I would like, or videos recorded, it just gives a more robust support for a caregiver who's making decisions.
Yeah. This is fantastic. Peg, I want to thank you so much. These are difficult, like I said, conversations for folks to have, thoughts to be thinking about. And certainly, again, we get so many questions. I can't tell you how many times I hear people say, oh, if I got Alzheimer's disease, I would just do the death with dignity. I would just end it. It's really easy to say those things when you're not in that position. And this is just a good opportunity for folks to think about what really are the options and what really does it look like and who does it apply to.
Yeah. If folks want more information, our websites, which is deathwithdignity.org, has a lot of good information, and that's a good place to get more information if folks are curious.
Fantastic. Thank you. I will definitely add that to the show notes. I'll put Amy Bloom's book in there. Is there anything else you can think of that would be helpful for our listeners to access? One of the things I'm wondering is if you have a good resource for having that conversation, or making your wishes known, or creating a video, or
I haven't scanned around the internet right now, so I apologize. I don't like have those kind of like, I feel like that's in my social work toolkit.
I got you. Yeah.
So
No, but this is good.
apologize.
I mean, just calling it out so people do some research.
Yeah.
Look it up. Yeah.
Yeah.
I'll poke around too and see if I can add something as well. But specifically for dementia, I think that that's where obviously our listeners are most interested in, but I think the general public, I mean, this is, I don't have my statistics in front of me either, but when we look at causes of death, dementia is up there in the top 5, and of terminal illnesses. And so, this is no small thing that people are asking these questions for a reason. So,
yeah. Again, I can really sort of, the struggles of being a caregiver resonate with me. Personally, I've been there, and as a social worker, so I very much understand the like, this is a tough problem to solve. It's very hard.
yeah. Peg, thank you so much for joining us. And I just appreciate your time so much. And we will keep in touch. As things change and policies change, I just want to thank you for the work that you're doing, because we need it clearly.
Well, and thank you, Laura, and thank you for your podcast supporting caregivers so much.